This next slide is maybe my favorite. Do people on the panel or in the audience, do you remember there was an interview maybe 2 months ago where Anthony Fauci was interviewed, and the interviewer asked, can you talk about natural immunity? Can you talk about whether these people that have had the infection, do they actually have enduring immunity? And his response was, anybody remember? That's a great question. I'll have to get back to you on that. So if you look at this study, this is an NIH study, and it's about T cells, right? Our immune systems basically have T cells and B cells. B cells make the antibodies. They're easy to measure, and that's often used as a sign of immunity, if you have antibodies or not. T cells, memory cells, they're really where it's at, especially with enduring viral immunity. So this is a March 2021, a year and a half ago, this study. This is a one-page summary of an NIH study. And it shows that at the time they had people that were infected with the original early pre-Delta coronavirus, and then they measured their immunity, and they found, using methods that you can't use easily in the lab, it's for research purposes, they found that they had really good immunity against the next subsequent mutations that came along. In other words, they had immunity that persisted, and it was broader than what you'd get if it was just from a vaccine. And I love this slide because at the bottom, it says who, and it says Anthony S. Fauci, Director-in-Chief, Lab of Immunoregulation, is available to comment on this research. This was a year and a half ago. All right. I want to move on to another area. This regards adverse events to the COVID vaccine. According to the CDC's website, they do a summary of all the vaccines that they had delivered from December 20 when it first came out through January of this year. And during that time, the VAERS, that's the Vaccine Adverse Event Recording System, they recorded deaths that worked out to, 2 per 100,000 people that got the vaccine died, according to VAERS. Anybody on the panel familiar with the reliability or how well VAERS is, how accurate it's generally attributed or credited to be?
Oh, I think you're referring to what percent of actual events are reported on VAERS.
Sure.
It's a fraction of actual events that are reported on VAERS. I mean, I think 10% or less are reported, so I think something like that.
For those of you who may not be familiar with how clinical trials are run, that was a hat I wore before medical school. And what happens is when you have a patient on either a drug or placebo, you fill out a chart. It's probably all on a computer now. And every single little thing that happens to that person is recorded. So a person has a sniffle, a person has GI distress, for whatever reason, it gets recorded. And it's up to the principal investigator to sign off on it and say, well, I think this is related to the medication. I think this is not related to the medication. They're blinded to this, by the way. So was it the late 70s, early 80s, after the flu vaccine, the drug manufacturers did not want to make vaccines anymore because of the number of adverse events related to it and the potential liability. So in order to get people to make vaccines and have a robust vaccination program in the US, that's how the VAERS was designed by the government. So it was designed to be queried every once in a while to make sure that they're not giving the population illnesses as part of a government program. However, it still has the same requirements as any other study. There has to be an investigator that signs off on it and says, I think this is related, I think there isn't. So it's not like it's a statistical or a lab-based problem. It still comes down to an individual investigator judgment. So I'm not saying people are influenced one way or the other. That's beyond what I could know, but There is significant potential for human error in deciding what is related to an intervention for a medication and what is not.
Another thing to consider is that we have a broad range of patients, the U.S. population, down to, what are the latest recommendations? Down to 5 years old, or do they want to, some people want to vaccinate them down to a year and a half, right? Is it 6 months? So here's the way to think of this. If you know the risk of death, let's just say it's 2 in 100,000. We have very good reason to expect that it's much higher than that, but even if it's 2 in 100,000, the way you would apply that to a decision about vaccination would be, well, okay, what's the risk of the infection? You're going to give a vaccine to prevent death, like I think Doug was saying earlier. Okay, well, what's the risk of death that you're preventing? And then whichever is the less death, that's one you might want to choose. I can't think, Melissa, maybe you can think of one. I can't think of another example in medicine where you've got a risk of death in an elderly person with diabetes, immune problems, maybe a risk of death that is 1,000 times higher than the risk of death for a healthy young person under 20. I can't think of another example in medicine where you would apply the same treatment to two people with a 1,000-fold risk differential. Does that make sense, what I'm saying? The example I often use is the BRCA gene, the breast cancer gene. If you have this BRCA gene, maybe it's both genes, and if you have that, your lifetime risk of breast cancer, instead of being about 9%, it's 90%. So that's a 10-fold increase in your risk of getting breast cancer. And with that kind of risk, it's standard approved, I think reasonable medical practice to offer a woman with that risk of breast cancer, say, hey, you may want to consider preventive mastectomy. Just so you don't have to mess with this and miss it, you may want to have mastectomy so you don't get cancer. But what physician, for a regular woman without the BRCA gene and a 9% risk of breast cancer, what physician would say, hey, you really ought to think about preventive bilateral mastectomy so you don't have to worry about cancer? That's with a 10-fold increase. Now we're talking in the case of COVID and these vaccines, a 1,000-fold increase. That's literally in the ballpark of a man getting breast cancer. So that'd be like a doctor, it's the equivalent risk-wise of a doctor saying, okay, you got to have bilateral mastectomy just so you don't get breast cancer. And I can't think of another example in medicine where they do that. Scott.
Well, the argument they use to vaccinate the children is not, you could say, well, the children aren't dying from this. They're not even getting sick from this. And they say, yes, but they must get vaccinated to protect grandma and
right.
grandpa, great-grandma. So I ask you, when in the history of mankind has any healthcare policy ever said we must sacrifice the young to save the old? I mean, give me a break.
Go ahead.
And talking on adverse events, so there was a study done out of Hopkins of over 800,000 under 18, and they found that for every one hospitalization prevented, there was between 18 and 98 adverse events. And these adverse events, as we know, are, they're blood clots, there's stroke, myocarditis, and even while I was at Prevea last year, or actually shortly after I left, they sent out a BPA. So what that is it's a
Wait, Melissa, why would you leave Prevea?
Oh, that's a good question. So
Don't lose your train of thought. Just
okay.
Stick it in there.
Okay, real quick. Well, when the mandates had rolled out, that was a little bit too much for me to handle. I was currently the supervisor of the vascular surgery team down the hall from Clemens, and my surgeons did surgeries with Chabot, and I loved the team. They were my work family, and truly cherished that position. But there were members on my team that they didn't have a religious conviction, but they didn't want to get the vaccine for reasons that were personal to them. One had an autoimmune disorder, and but that didn't matter, and it mattered to me. And so I was protesting on my lunch break and organizing protests in the community, and stirring up some ruckus within Prevea, and so Prevea's attorney decided to bring me corrective action, and that's when I decided I didn't want that fight. So I left to take care of my grandma in hospice and spend some quality time with her. So
Yeah, all right.
Yeah.
Well, thank you. I didn't mean to
Yeah.
derail you from your...
no, that's okay. That's okay. And a shout out to everyone that's here that protested with me. Appreciate you all. Okay, so then after I left Prevea, of course, we have this group chat of all of these Prevea members that were against this mandate. And shortly after I left, I got a screenshot of this BPA. And what a BPA is, it's a best practice advisory. So when you're providing care to a patient, and if something, if a couple things line up, they're like, hey, check this out. Well, this BPA was put in for young males, teenage boys that had the vaccine that would come in with shortness of breath because it had been correlated that they were at risk for myocarditis.
Yeah. Well, this slide up there now is from June of this year, and it's an article, an editorial that was in the Lancet, and it is a recommendation by this expert, and he's not alone, that these vaccines now are considered damaging to the immune system. In his opinion, not just not effective against the COVID vaccine, but that they actually are impairing your immune system. And there's a line that I highlighted there. As a safety measure, further booster vaccination should be discontinued. Part of it is, you think of, the vaccines might make sense for the elderly, for people that are more at risk of the disease, so you want to prevent the disease more with the vaccine. Now the recommendation for many experts is the elderly are the ones you least want to give this vaccine to because you will further impair their immunity. They even mentioned that if you're going in for an operation, a surgery, don't get the vaccine because it can make you more susceptible to perioperative infection. If you look at the I threw this in. I don't want to do that now.
Sorry, what was that? That was a letter to the editor, right?
Yes.
So what was
Lancet.
where did that writer get their sources?
I don't know. You'll have to. Why are you doing this to me? I'm in front of people.
Because it's supposed to be rational.
We're doing this live.
Always devil's advocate.
I shouldn't be flippant. We do have the sources on the website.
Okay.
He was referring to, he was writing in the Lancet, and I think he was an author of an article in the Lancet, and he referred back to it, but I don't know it off the top of my head.
I just mention one thing.
Sure.
With respect to, I have a personal experience with the myocarditis, pericarditis problem. When my teenage son decided to get a second dose of the vaccine, on the day that I had to drive him to the ER with chest pains, I decided that something's kind of wrong with this. Something, is not quite adding up. Anyways, I did do some research. The latest study on myocarditis in men under 40 is that the excess risk is about 10 in 100,000. So based on data from Israel that I've looked at, this is from 2021, the risk of a severe case for a 16 to 19-year-old or for a 12 to 15-year-old is 1 per 100,000 for a severe case. So you're talking about a myocarditis risk roughly around 10 per 100,000 versus a severe case of 1. So now, for an elderly person, the risk is much higher. It's about 300 times that of someone who's between the age of 12 and 15. So it might make more sense, to weigh the risk and reward. But the idea that we wouldn't stratify for age we wouldn't nuance it, and we would just say, everybody get a vaccine, it's safe and effective, regardless of age and regardless of the new knowledge of these side effects or the adverse events, I think is just ridiculous.
And the other thing,
Sorry, I missed something in there. So what is the risk of myocarditis in his age group?
Under 40, it would
Yeah.
be about, that was a blanket under 40. It was
Yeah.
9.7
Okay.
per 100,000.
And what was the risk with the vaccine?
The risk with the vaccine is if he gets the vaccine, his risk is 9.7.
Okay.
Without the vaccine, it was 1.6.
Okay.
So it was almost
So
6x.
that's comparing one group to the other, one that got the vaccine historically without the vaccine and now one with the vaccine. So that's not a perfect comparison, but that shows two groups, two cohorts, and that's kind of data that we need to look at.
To be fair, there's a risk of getting myocarditis
With COVID.
with the infection.
Yes, yes.
And most people, the rates are actually a little bit higher or can be higher depending on the age group. The risk of myocarditis from the infection can actually be worse than the risk of myocarditis from the vaccine. But in this under 40, particularly men and teen boys, which is, this is kind of a well-known fact now, the risk is escalated for all the three major vaccines, particularly after the second dose.
so if you look at
So
this next.
so I had a question. I'm not going to stand up.
Yeah, you gotta
It's a
stand up.
No, it's just,
Well,
it's
listen,
just a question.
I was letting these guys.
So you're talking to the ER doc, your son has shortness of breath, and they do an EKG, and I know maybe they did a D-dimer. D-dimer's against the law. Maybe they did an echo, who knows. But in the end, they said he has myocarditis. Was there any mention of the vaccination? Did
No,
they ask the
They
question?
said he had pericarditis. I think it was more of an inflammation rather than the heart actually being inflamed. And I said,
Did he get it off the toilet?
I said, it's kind of interesting that he just got the second dose today. And she was kind of like, yeah, but she couldn't really say anything, right? But she was clearly like, yeah, something, it's obviously related. But she really couldn't officially say that because she didn't have the study.
So you're hearing now side effects of the vaccine. Back to the CDC website. This is an explanation of